Yes, hi, it's Dr. Jeffrey DeSarbo again. I want to thank you for tuning into this episode, and hopefully you've seen the ones before it, and we'll continue to watch the rest. This is NeuroSeries number 9, which is on the psychology and therapy, and the neuroscience behind all of that, which I hope you'll find interesting. A lot of people think when I work in medicine or I talk about neuroscience and neurobiology that that's just one completely independent realm, and then you have the psychologists on the other end. But say, when people are working in therapy and everything, there's a whole neuroscience behind that. It isn't just talking to an individual. Talking has significant implications on the brain, the mind, and the central nervous system. So let's get started. This was a very large study. It wasn't just about eating disorders, but it gave some really good insight into comorbidities of different disorders. Comorbidity essentially means if you have an eating disorder, what other conditions often go with it. Now, this looked at it was thousands. I think it's 6,000 plus people were involved with this study. You can see I have 3 columns here: anorexia nervosa, bulimia nervosa, and binge eating disorder. And these are the percentages in each of these different types of mood categories that have been found in people who have an eating disorder. So if we look at anxiety disorders, people with anorexia have close to 50%, bulimia nervosa, about 80% have a coexisting anxiety disorder, and nearly over a quarter with binge eating disorder will have an anxiety disorder. Mood disorders include things like depression, bipolar disorder, and you can see the numbers here. Impulse control disorders, also very high. Substance use disorders is like almost a third of patients will have a co-occurring substance use, alcohol, or an illicit substance that they use often as a form of self-medicating when they're struggling with anorexia, bulimia, and binge eating disorder. And the number of people who have at least one of these disorders, you can see here these numbers. Now, again, this is outpatient data, and if you look at people who are usually admitted to a residential treatment facility or higher levels of care, I would say that, like with anorexia nervosa, that too is close to 92, sometimes even 100%, but certainly it's in the 90th percentile, and that's one of the reasons why higher level cares are often required, such as residential treatment centers and hospitals. And of course, with bulimia nervosa, you can see it's close to 95%, and binge eating disorder too is almost 80%. So when we look at trying to work with somebody in a therapeutic type of setting, how do you control all those thoughts that are just constantly working around in someone's head about food, weight, body image, calories, exercise? And again, what I keep saying over and over is that intense level of distress that these thoughts cause. A lot of times people think, well, why don't you do things like knit? Why don't you do things like read a book, watch television? And they serve some role, but certain studies like this shows that distraction, just trying not to think about it, is not one of the best modalities for handling these thoughts. It sometimes seems to be the most common type of therapeutic coping tool that's taught. But studies like this have shown that they're real. So trying to suppress thoughts is actually something that makes a person often think more about them. So again, it's like you've probably heard it before. If someone says, "Don't think of a pink elephant," "Don't think of a pink elephant," "Don't think of a pink elephant," what are you thinking about? Okay, and it's the same thing when you're trying to deal with all those types of eating disorder thoughts. So distraction sometimes isn't the best method. So there are different types of therapy that are used when working with patients with eating disorders, depending on the type of eating disorder. One of the baseline therapies still remains cognitive behavioral therapy, especially when you look at published data and research. It's got a lot of support behind it. There are slight derivations off of what's called CBT, cognitive behavioral therapy, that have been developed, and they're pretty effective, although they may not have as much research behind them. One of the most researched techniques in dealing with eating disorder in children and adolescents is the Maudsley approach, and it has been adapted for adults as well. And that is something that was developed out of Maudsley in London, England, and it has a lot of research backed behind it to show its efficacy. It doesn't mean it's 100% effective or even 80% at times, and there's a very specific pattern it takes, but that takes place with it. But it is a family-based approach to treatment that does have some research. Other types of therapy are also out there, and there's several like ACT, which is acceptance and commitment therapy, DBT, dialectic behavioral therapy, which has been adapted for eating disorders. And there's other types of therapies that are often used. I myself even include existential therapy, which has, to be honest with you, not a lot of research yet. When talking with eating disorder patients, they often are very existential in how they think, kind of like why. One of the biggest existential question when working with somebody with an eating disorder is, why should I get better? And so we have to explore those types of things. And of course, psychodynamic therapies are often what many people are trained at. Has some research, but it's usually we need more of a cognitive behavioral approach to make headways with eating disorders. So like I said, an eating disorder itself does change the brain. Here's several different studies. One thing about watching this on video right now and on the computers, I'm always giving you the sources of the information. The yellow part, again, is the title of the articles. So if you ever want to look into, just Google this, look it up, or go to PubMed or something like that. You can sometimes find the full article, sometimes just the abstract. But this is just a sampling, again, and there's so many more published research articles in the scientific journals that show the different changes that take place in the brain with different types of therapy. And you'll see changes like a calming of that limbic system, a calming of that emotional brain that we discussed earlier in an episode. You get changes like in a decrease metabolism takes place in the caudate nucleus in therapies with people with like OCD. And again, because eating disorders involve those same circuitries in the frontal lobes, that's how it will benefit those regions of the brain as well. There's one study, it showed how there's a significant increase in metabolic activity in the frontal region. If you remember, I talked about the frontal lobes of the brain and the orbital frontal and the prefrontal lobes and that are required for high executive functioning and better processing of the world. And the study showed, people who had a response in improving those regions of the brain had better outcomes with their therapy. Okay, so again, the therapy itself can help the brain kind of change and improve, as well as other types of interventions. Sometimes even that's why they say medications with therapy work better. And if you look at one of, I'm trying to think of which study it was, but it was in one of these here. It talked about how there's a different type of imaging markers that are being studied that can predict the different types of therapy benefits that take place with the brain, which may help dictate what therapy to use, what type of approach is needed, even using outside biofeedback, neurofeedback mechanisms that can be incorporated into therapy to help with targeting some regions of the brain that are affected with eating disorders and other conditions. There's also a study here that looks at brain imaging and psychotherapy that shows, I mentioned that caudate nucleus having significant improvements with people with OCD. And then in phobia, brief courses of behavioral types of therapy have helped reduce paralimbic responses. That means that's kind of like that, your body's shaking, you're a nervous wreck, you feel like adrenaline's flowing through you, you're on high alert, ready to flee, and it shows behavioral therapy can be kind of very helpful in those types of situations. The prefrontal metabolism is significantly important in things like depression, and when they look at certain studies, it shows that therapy works on parts of the brain sometimes that medications don't work on. And that's what in this study they kind of refer to as psychopharmacology. The use of medications works kind of like a bottom up. Let's see if we can help restore the functioning of the brain, and then people can start to do better therapy, and the person then feels better. And psychotherapy works often from a top-down approach, which is, well, let's try to work on some of the thought processes and behavioral aspects of how an individual is going about their day. That will then help heal the brain and, again, bring about that better quality of life in the end. So just to give you an idea, because I think it's important to understand for those who may not be familiar with eating disorders that well, the whole concept of the therapy that's involved with an eating disorder. I always ask this question to people. What's the number one rate-limiting step for recovery? In other words, what's the number one roadblock? Why is it hard for people to kind of to get into recovery? Or they work up to a certain point and then bang, it stops, or they have to go backwards. And the straight-out answer is their ability to tolerate pain. We're not talking about physical pain necessarily. We're talking about emotional pain. It's a psychological warfare that's going inside the individual's head. Therapists and clinicians in the field, we're usually saying there's this battle between who you are as a person, let's say you're Jane Doe, and then you have Ed, eating disorder. And those two internal dialogues are fighting each other. It's a tug of war. Sometimes Ed, in an intense treatment, or you go into residential, initially gets super loud, but then kind of sits in the corner, figuratively in the back of the brain. And a person starts to develop some of their own will to kind of push themselves forward through recovery. And then as soon as there's an opportunity, whether they're discharged from treatment or there's a trauma or something goes bad or they see a number on the scale, that Ed gets out of the chair and starts triggering off and firing off its own pathway, and it becomes very painful psychologically and distressing to the individual. That's why when I talked in the last episode also about trying to stay off scale, that can be one of the pains that people put themselves through on a daily basis, and sometimes on a frequent, multiple times of pain on a daily basis. So pain is the main blockade that somebody has to work through if they're going to continue to move forward with their treatment. So I always say there's this bottlenecking in treatment. You've got these expectations and judgment and who you are, your identity, and you have all these concerns, your health, your moods, fears of failure, family issues, school issues, thoughts and character traits like perfectionism. How do you handle and cope with friends and peers? Have you had traumas and they're still, kind of coming up, and flashbacks, nightmares, things you think about? The treatment itself can be painful. It takes a lot of time. It can cost a lot of money. It's worrying about disappointment, or you hit slow periods and you feel like you're no good and you're not making progress. There's worries about careers, for younger people. What do I want to do with my life? For people who already have careers, how is it falling apart? How's this affecting it? What's going to happen if I'm in treatment? Social media has an impact on creating pain. It's like I said, we could do days on talking about the impacts of social media on the brain, central nervous system, and psychology and distress. There's peer pressures. Especially in these days, there's more and more new things that an individual feels they have to conform to in order to feel accepted, or that fear of judgment again exists. Sports and athletics. If you like them or if you feel you need to do them. It's way too often I'm working with athletes from all levels, from sports in the community to high school sports to Division I athletes to professional athletes and several Olympic athletes that I've worked with. And it's amazing that, you've had these people who have given so much to reach high levels in their sports completely disdained and hated the entire process they went through, and there's been fallout from it. Some have eating disorders, some have problems with addictions or other emotional issues. Dress, again, one of the most difficult things every day. What do I wear when I wake up in the morning, or do I just not even bother to go outside? So all of that, all this bottlenecking, all these things enter, and you get a lot of pain emotionally, okay? Now that's where you kind of get stuck in treatment. And the way you're going to get through it again and opening up is going to be learning how to tolerate pain. And that's when you can do that is where you can keep working on your coping skills, your life strategies, your expectations. And those things there help restore the brain and the central nervous system. I always say if there's one emotion, if you want to eliminate an eating disorder, eliminate fear. Okay? If you eliminate fear, then you don't have a fear of expectations, judgment, what other people think. You don't have a fear of food. You don't have a fear of what a number on a scale says. You don't have fear of body image. So fear is like uncertainty. Fear is the unknown. And so many people live in and around that emotion, okay? And it's a very painful emotion to live with, I always say, like, our brain is supposed to understand fear. If a tiger walks into the room with us, that amygdala is supposed to fire off and we need to take action. If we have to cross a busy street, that amygdala should kick in. We should be looking both ways and making decisions based on that. Modern day society, though, we now fear things that evolution, from an evolutionary perspective, we're not supposed to fear. Like, what does my neighbor think of my car or something like that? But yet we still do, and that causes great distress and pain. So the question is, how do we increase the ability to tolerate pain? And sometimes when I've done this slide here in some of my presentations to treatment providers, and how are you going to handle therapy? This is a key thing. This is like, we have to help people with an eating disorder learn to develop the ability to tolerate pain, okay? And that's not an easy thing, but these are some of the things that you have to do. You need to understand its role, okay? Kind of what I spoke about with fear is there for a useful purpose in most situations. You have to acknowledge the things that you are afraid of. You need to talk about them. Cognitive behavioral therapy helps you distinguish, is this a rational fear? Is this an irrational fear? And even though many people know many of their fears are irrational, that doesn't make it go away, okay? But you still have to kind of acknowledge it's there and understand it. You don't want to avoid it. You want to go head on for the most part. I think the whole thing on the quality of life is, even for myself personally, I do this thing that if I have certain types of fears, it makes me want to go head on and do it. If I have a fear of heights, I think my best ability to conquer that was I went bungee jumping in New Zealand, okay? I had a whole technique, how I mentally prepared myself. That's another story. But it was a fantastic experience, not to mention that I felt really proud and accomplished that I challenged that fear. And did what I say, it's extinguished my fear of heights? Maybe not, but it certainly has significantly decreased them. Exposure therapy, that's flooding. Again, I guess if I have a fear of heights, somebody could have just taken me up to the top of buildings and made me look over the edge and stuff. But exposure therapy, you see it's a little asterisk there. That's actually a lot of the behavioral therapy and the treatment of eating disorders. I fear certain types of foods. I fear certain types of meals or quantities. And when people go and they work very closely with their nutritionist, or they're in a residential center, a hospital, or an intensive outpatient program, and they're given a meal to have and hopefully coach through it. That's that exposure therapy. We're gonna put the thing that scares you, and we're gonna kind of help you through it, but we're not going to avoid it. We're not going to work around it. Brain training, or do things like mindfulness training. Again, biofeedback, neurofeedback techniques, very helpful to learn how to keep yourself calm and challenge yourself with fearful things. Change your global belief systems. And again, that's that existential approach to life. Kind of like global belief systems are like, the world is really falling apart. And, cognitively, you might challenge that to say, well, where are we as far as, our advances in health and medicine? Where are we as far as rights that have been extended to certain groups of people and populations? It's never that the world is a perfect place, but we're used to kind of trained in our society to think in more of a catastrophe type of thinking, that things are really getting bad, everything's falling apart. And without getting into a sidebar or anything, that's usually because we are in a economically driven economy, and if you want to sell products, the news, the media, social media, everything is, if you want to get attention from people, the two emotions you try to generate is either fear or anger. And so if you just think about for that minute, if I can create a television station, I can get most people really fearful or angry about the stuff I want to kind of put out there. I'm going to get high viewerships. I can sell more products. But then that affects the actual psyche of not just an individual, but a society. Gratitude practice, again, overcoming tolerance and pain, is always thinking. It says times 3,650, 10 times a day. Take gratitude for the things you have, the things you take for granted. The fact that, you may have two legs, the fact that, you have certain things that other people only wish they had, and opportunities even. And it's no matter what there's something with pretty much everybody. You can find things to think about every day that you take for granted, that you really have to practice showing appreciation before you start to go into that realm of thinking that we're often trained of. I'm happy because I don't have this in my life. And so again, that's the type of thought process that causes pain. Now, another concept in therapy, it's exemplified by something called the Benjamin Franklin effect. And it's this, people think a certain way, like, well, I would like people to like me. And there was a study done. It said, where will people like you more if, let's say, they need your help and you help them do something, or if you need help and you ask somebody and you let them help you? And that's a question you might think about, and you probably know the answer is going to be the likability factor with the Benjamin Franklin effect is people like you more actually if you allow them to help you. Now, this is interesting, and I use this as an example when I talk with people with eating disorders, because most people with eating disorders, they're more than willing to help another individual, to talk to them, to have empathy towards them, to go out of their way to make them happy. But yet that Ed voice inside says, I'm not worthy of it. So they usually won't, they're going to refuse help. They're not going to let people help them. They won't open up and share some of their difficulties. And this leads to, again, the individual not only feeling like they are worthy of something, but it doesn't let those around them participate in something and make them feel good about their interaction with that person who might be struggling with an eating disorder. And a lot of this involves the concept called cognitive dissonance. Now, cognitive dissonance, it's something, it was kind of defined by this psychologist, Leon Festinger. He's actually very famous. He's like the third or fourth quoted psychiatrist in history, behind Freud and a couple others. But he says it's really our struggle to reconcile conflicting ideas about ourselves, others, and situations. And so there's this study that was done. It looked at the brains, and they put up people in an MRI scanner, and they presented them with political opinions that were in direct conflict and opposed what their own personal stance was. And what the MRI showed is the highest rates, the highest thinking parts of the cortex that are responsible for things like rational thought actually got less blood flow until another statement was made that kind of was more in line with that individual's own political thoughts and views. Okay, so the study is kind of saying that if you're talking with somebody who has a significant imposing view, what takes place in the brain is that their brain just shuts down when their own ideology is kind of threatened, and when you're challenging something they have a strong belief something with. So, I think we what we see when we talk to somebody and we present an opposing idea is they're just not listening to us. Well, that's true, but they're not listening to you because their brain just shut down. They're not going to hear it, you know. I always like people to keep that in mind so that maybe people don't keep going on and on when they recognize this is happening when they're talking with another individual. So how does this affect eating disorders? So here you got Ed's brain saying, I don't want to eat this. If I do, I'll gain this amount of weight. I really look horrible. I weigh a ton. And a therapist or a family member starts challenging those concepts. Well, they're higher functioning areas of the brain. When they're presented with conflicting ideas that challenge the eating disorder thoughts take place, those parts of the brain shut down too. So, you know, the interesting thing is I'm often saying when somebody has a therapist is like, are they a specialist with eating disorders? And it is important to have people who even understand these biological concepts of therapy, because you have to know that if somebody just keeps there insisting over and over, forcing kind of like cognitive thoughts over and over, it's not going to get through until you can learn how to kind of bring the person where their brain will not shut down. So you got to, the way you challenge thoughts in a cognitive behavioral approach is slightly different than you might with other individuals, although probably in most cases. Now, there is this thing with traits that are common to eating disorders, and perfectionism is one of those traits. You know, people think, well, if I'm perfect then, and usually the answer is if I'm perfect, if I'm the best at in academics, if I'm the most popular, if I'm the best looking individual, if I'm the best at achievement and success, usually the then always boils down to people will like me, and because that biggest fear so many people have is loneliness. But interestingly, if you are perfect, think about it for a moment. If you know anybody who you are with or spend time with, and you just know this person is smarter than me, this person is better looking than me, this person is funnier, this person is more successful, how does that make you feel? Okay, it doesn't usually make you feel great, So a lot of times I'm working with these amazing people that do have gifts like their intelligence and their humor and their personality, and I have to tell you that, and when I'm working with them, I'm part of the training is kind of like you have to learn to become a little self-deprecating, humble is maybe a better word. And that's how people get attracted to another individual, not by trying to show off you're the best or you're any of that. Now, the trait of perfectionism, as I put this slide up, you'll see it says 30 to 42%. The GF is genetic factors. So we're finding out that even personality traits seem to have a strong genetic linkage. So, it's something that seems to also then you find with many eating disorders is perfectionism is kind of linked to it. So I put that up there again just to show that there's still this biological input that takes place with even things like personality characteristics. And again, kind of like working cognitive behaviorally, I try to work with the concept that, perfectionism is kind of a flaw. Not only is it inachievable, but it is a flaw. We often will then, try to arouse cortical function and by kind of instilling new belief system. And one of my favorite sayings that I heard, decades ago is perfectionism is driven by fear. Excellence is driven by passion. And again, a lot of times when working with people I work with, focus is on what are you passionate about? Where does your passion lie? And how are you going to go for that? So just to conclude, this was something that was published rather recently. Just talked about kind of the importance that there is that clinicians, especially non-medical clinicians, have to develop a basic knowledge of neuroscience to kind of approach a patient on a more scientifically holistic approach, and that they should be, and I hope studying and following the neuroscience if in their field specialty, in this case eating disorders, so that they can really understand what's taking place from a neuropsychological and a neurobiological perspective, even if they're doing just psychotherapy. Okay, So I'm going to continue on next to episode 10, Neuroscience of Medications, and I hope everybody will continue to follow. The information again at the end of each of these NeuroSeries, you can pause it if you ever do want to reach out for a comment or question or anything else. And I hope to see you in our next episode.